Hello, my name is Dylan Hoffman. This is my presentation on injury prevention using a disablement model. I'm a first year student in the Indiana State DAT program, class of 2021. So before we start with this presentation, I want to give some real quick background and how I'm going to kind of apply this to what I've been seeing in my own practice. In my own practice, I've had a large number of my lower extremity injuries in the last 2 months being lateral ankle sprains. And so I've done some looking into what are some of those risk factors? How do those apply to this disablement model? And specifically, how does that apply to a disablement model for injury prevention? When I'm talking about a disablement model, what I'm talking about is this here. And you can see that how it's basically set up is we have risk factors that are triggered by some kind of external event, such as stepping wrong, getting hit, one of those things, that causes the disabling process to start to go into place, where you have a pathology leading to an impairment, leading to a functional limitation, leading to a disability, and then how that's going to affect a patient's health-related quality of life. When we look at risk factors, we can look at them in three kind of sections. That's biology, environment, and lifestyle behaviors. If we're going to look at that specifically to my case, the lateral ankle sprains, we can look at it as lifestyle being things such as the sport they're playing or their activity level. We look at the environment on what are they playing on? Is it turf? Is it grass? How well is the field kept? Is the field wet? What's their footwear? And then biological risk factors as well, such as what's the laxity or integrity of the ligaments, muscular strength, their poor balance, and there's even some other kinds of intrinsic factors such as potentially weight or height involved in that as well. And one thing I do want to make clear is that these risk factors, for the most part, are very conflicted when you look through the research. There's not a large consensus on these are true risk factors, but these are some of the ones that are at least debated in the current literature. So we have an event, our ankle goes into deep inversion, and we have a pathology. That's a lateral ankle sprain. Looking at the impairment, what's immediately impaired, the ligaments are compromised, and we have inflammation that comes in. We can look at the functional limitations as well, decreased range of motion, decreased strength, and we can look at how that affects disability, their inability to run or walk, or in this case, inability to play sport or time lost from that sport. Now, all of that's going to directly affect a patient's health-related quality of life. They may not be able to do their ADLs. They may not have an easy time going to class, which can affect academic performance, an inability to play their sport. This may cause them to have some issues with their identity as an athlete or as a student, their social roles with friends or with their teammates. And this is going to affect potentially their mood and emotions as well. So there's a direct correlation between a patient that has these risk factors, has an injury, goes through the disabling process, and may have a lower health-related quality of life in return. So the main purpose of this is, how do we prevent that from happening? And we do that by looking at some prevention strategies and really creating a game plan of how are we going to prevent these lateral ankle sprains from occurring. I want to always start with the same way our model starts, which is risk factors and identifying risk factors. As I said, the research is not at a consensus, but it's really important for us to continue to look and build a consensus on what are the true risk factors for lateral ankle sprains. Once we start to determine that, we can determine which of those risk factors are modifiable, which ones can we actually affect and change. And we can do that and identify that in patients through injury screening. And then the third step of this is to actually make those changes. And yes, we can make those changes at an individual level, but I would much more prefer to make those changes at an organizational level, especially if it's, say, we need to increase neuromuscular control. That's something that we can start to implement into our conditioning programs and do at a larger, more massed level. When you're looking at what the research does say, as far as effective preventive strategies, it's really ankle bracing and neuromuscular training. Obviously, ankle bracing has been shown to decrease the chance of suffering from a lateral ankle sprain. It's important to understand that there may be some negative effects towards repetitive ankle bracing, but all the literature does show that that supports it, especially in a situation where they may be at a high risk, such as playing a basketball game much more than, walking to class. And along with that, ankle bracing is increasing their neuromuscular training and control in the leg and lower extremity and even the core. And those two together can really help us prevent some injuries and hopefully stop this disabling process from occurring and keeping our patients living a higher quality of health-related care and life. So that is my presentation on the injury prevention using a disablement model. Again, my name is Dylan Hoffman, and it was a pleasure to talk to everybody today.